Okay, here we are. Welcome everybody to the December PEP Talk. We're excited to have everyone here with us this evening. As you know, this is Patients Educating Patients presented by the National Blood Clot Alliance, and we're super happy to have you here today. Tonight's topic is one that many find themselves navigating, unfortunately, often with too little guidance, navigating life after a blood clot diagnosis. So whether you're newly diagnosed, you're in recovery, or you're supporting somebody that you love, we want you to know that you are not alone and we are here to provide information to you. Um, Before we begin, we do want to remind people that this session is for educational support only and does not replace care from your personal health care provider. So please talk to your medical team about any specific medical decisions that need to be made on your behalf because everybody is different. I am joined tonight by my PEP partner, Todd Robertson. Todd, thank you for joining this evening.
Mhm.
And back by popular demand is Diane Wirt, who is now, I think, Diane, this is your fourth time this year joining us on this particular topic. So thank you for coming back. For those of you that are new that don't know Diane, just a little bit of information about her. She is a nationally recognized, I would even say internationally recognized expert in venous thromboembolism and in particular anticoagulation management with more than 3 decades, can we say that, of clinical experience. Diane has led major anticoagulation and cardiology programs at institutions including Emory Healthcare and Grady Memorial Hospital, where she helped establish an award-winning heart failure program. During her tenure at Emory, she managed 8 anticoagulation clinics. I don't know how you did that, serving more than 3,000 patients. And she later built a large virtual anticoagulation program, training more than 300 patients to self-test their INR at home, a real game changer for a lot of people. Diane is a board certified as an adult nurse practitioner. She served as the treasurer of the National Certification Board for Anticoagulation Providers, is a certified anticoagulation provider, and she has collaborated with both the CDC and the National Blood Clot Alliance on national education initiatives, training clinicians across the country, and is a frequent contributor to professional publications and training programs. So we are excited to have you back, Diane. Thank you so very much for joining us tonight. So before we get going, I'm going to turn it over to Todd. Todd and I are competing on what's the coldest place, and maybe you win tonight. Maybe I win tonight. I'm not
I
sure.
got the most snow, that's for
I
sure.
have no snow, but I think I have 25 degrees tonight. So I may win the temperature competition.
Yeah,
I know we have some poll questions, and I'm going to turn it over to you.
we do. Those are going to pop up. I'll read those. And every time you list the credentials for Diane, my head just spins. There is just so much that she's involved
And I
with. But
watered it down, just so you know.
and you watered it down, you
I
shortened it
did.
up. Folks, real easy questions. This is how we do it. We're going to ask some questions here at the beginning and then at the end of the episode. If you could just answer these real quick, and then we're going to read the results. I feel confident knowing what questions to ask my doctor after a blood clot diagnosis. Yes, no, not sure. Our second question, I know at least 2 steps I can take to lower my risk of another blood clot. Do you know 2 steps? Yes, no, not sure. And the last question, I feel confident in my understanding my anticoagulation treatment. Yes, no, not sure. And then we'll just cover those results real quick and then get into the meat of the show. This is like our holiday special. And here we go. I feel confident knowing what questions to ask my doctor after a blood clot diagnosis. 30% says yes, 35% no, and 35% not sure.
Hmm.
I know at least 2 steps I can take to lower my risk of another blood clot. 62% said yes, 13% no, and 26% said not sure. I feel confident in my understanding my anticoagulation treatment. 47% said yes, 26% no, and 26% not sure.
So we have some work cut out for us for sure.
Mm-hmm.
Okay. All right. So Diane, let's start at the very beginning. Tonight's first question for you. So many of us actually did not get an explanation on what should be 101 on blood clots. What is a blood clot, a venous blood clot specifically? What's the difference between venous and arterial? And then what's the difference between DVT and PE? And then explain to us what is meant by you have a provoked clot versus an unprovoked clot?
Okay, so let's start at the very beginning. So, unfortunately, when you first have a clot, like Leslie said, you don't get all the education. And even if you did get it, are you going to remember it because you're in such a state of shock and stress? So, oftentimes, it's not the best time for you to receive that education. And sometimes it's better to have another session with your anticoagulation provider and write those questions down. So, let's start with the first question. What is a blood clot? Well, it's a clump of cells, is what it is. It's a bunch of red blood cells, white blood cells, platelets, clotting factors, and then it forms a fibrin mesh that eventually will block if it does block a blood vessel, causes problems. And it can happen for a variety of reasons that we'll go through later in the talk. But they're usually there's you've got venous thromboembolism encompasses two types of clots: the deep vein thrombosis, which are typically found in your extremities. Your lower legs are the most common, and then your upper extremities, your arms, are the second most common. But then you can have weird clots that are also part of the venous thromboembolism cascade, like a portal vein thrombosis or a sinus thrombosis in the brain. Those are also types of venous VTEs. Pulmonary embolisms are a clot that has moved and lodged in your lungs. Almost always have moved. Occasionally, it's been felt that they have formed in the lungs, but typically they're a portion of a clot, or the whole clot breaks loose in the lower proximal legs and migrates up through the vena cava and lodges into a bed of the arteries in your lungs and causes you to become short of breath and can cause you to die. If you have a settled pulmonary embolism, oftentimes your presenting symptom is death. So pulmonary embolisms are always much more concerning because people die from them.
Mm-hmm.
Um, whether it's provoked or unprovoked is um, the conundrum. So we can surmise that a clot is provoked if, say, the patient has had recent surgery or trauma, if they've had an indwelling catheter like a IV, a port for chemotherapy, and they form a clot there, or a PICC line. Those are thought to be provoked. If they've had prolonged immobility, where maybe they broke their leg and they were in a cast and they weren't moving around as much, that would be considered provoked. Or they had pneumonia and they were in bed for 2 weeks or in the hospital for 2 weeks. That's why when you go to the hospital, they are very diligent about prophylacting patients with those shots in your belly, usually to keep you from forming clots because you're not moving. Other types of provoked clots would be oral contraceptives, birth control pills, estrogens, testosterone supplements. And then another provoking condition would be pregnancy. Women that are pregnant are 5 times more likely to form a blood clot than non-pregnant women. And then the other big one that is provoking is cancer. The unprovoked are the ones that just appear out of nowhere, where there's not a clear reason for someone to have a clot. They just present with either a red swollen leg or shortness of breath and tachycardia, which is fast heart rate, or their oxygen levels low, and it's discovered that they've had a clot that's gone to their lungs. So that's the difference between the provoked and unprovoked. The unprovoked are more concerning because we don't know what caused them, and they're more likely to reoccur than the provoked. So we'll get into some of those statistics a little bit later, but there are big differences between the provoked and unprovoked.
So provoked means they have a reason why you got a blood clot, and unprovoked means they don't know why you got a blood clot.
Right. Yeah.
Right.
Correct.
But blood clots aren't always bad, right? So we need
No, because I mean, when you think about it, when you cut yourself and you form a scab, that's in essence a clot. You don't want to bleed to death. So you have a mechanism in place, your clotting cascade, that's triggered when there's a break in a blood vessel and you form a clot. If we weren't able to do that, then every time you cut yourself, you would bleed to death. We also have the ability to dissolve the clots otherwise your scabs would stay forever. So you have proteins that make clots and you have proteins that dissolve clots.
Oh, that's interesting. I've never heard anybody mention the dissolving part before. That's actually really interesting. So with that, I'm going to turn it over to Todd.
Yeah, clots are great when they pop up and do what they're supposed to do. It's the abnormal clots that get in our way. But thank you, Diane. So once someone hears these words, you have a blood clot, regardless of what kind of blood clot it is. The next question is usually, well, what happens now? So after diagnosis, most patients are prescribed a blood thinner or an anticoagulant. So I've got a four-part question for you. I'm going to give them all to you now. How do anticoagulants work? How do clinicians decide which one to use? Because there's more than one DOAC and more than one anticoagulant. And for how long? How do they figure those two things out? Why is consistent dosing so critical? And what are the risks? And can someone stay on a blood thinner long term?
Okay, so let's start with the first one, which will kind of piggyback on what we were just talking with Leslie about. So, anticoagulants are often referred to as blood thinners, and that's a little misnomer. They don't actually thin your blood. So, what anticoagulants do is it slows down your body's ability to form blood clots. And it does this by blocking different clotting factors. So, in warfarin, you have four clotting factors it works against. And dabigatran, which is not widely used as much as the other 10A inhibitors, dabigatran is a thrombin inhibitor, where Eliquis and Xarelto, they block the action of activated factor 10. So it slows the body's ability to make clot down while your body dissolves the clots. So I describe protein Cs and protein S's as the Miss Pac-Mans, that they constantly go around your body chewing up the clot. And we're going to talk a little bit about D-dimers, but that's what Miss Pac-Man does, is she chews up the clots and makes D-dimers. And that's normal. Everybody, you're making a clot. I'm making a clot, and I've never had a blood clot, but I make clots all day long, all night long. Everybody does. When the numbers get too high and you're making too much clot, that's when it becomes a problem. Once you're diagnosed with it, then there's many things to take into consideration. So oftentimes patients, if they're not stable, will be started on an injectable form of heparin, either low molecular weight heparin or unfractionated heparin, until they stabilize, and then they'll switch to an oral medication. Some of the oral anticoagulants rely on a lead-in of low molecular weight heparin, and endoxiban and dabigatran have a lead-in of about 5 to 10 days. I think it is. I've never used either one of them. I've never prescribed them, but they're on an injectable for days and then they start the oral. With Xarelto and apixaban, they just start on the drugs. Warfarin will usually start with low molecular weight heparin and or unfractionated heparin until their INR is therapeutic. And it just really depends on what's on formulary at the hospital, which drug they use, or what the patient's insurance dictates, what the cost to the patient is going to be, because some of our patients that are on a fixed income, when they're on Medicare, $45 may be their copay, and they can't afford that. So they opt to go on a warfarin then. What other disease states do they have? Is there an underlying liver disease or kidney disease? Because some of these drugs are cleared through the liver, some are cleared through the kidney. And then what's the patient's preference? Do they want to be on a once-a-day med or a twice-a-day med? Do they want to be on a med that has to be monitored frequently, like warfarin? Or do they want, to just be able to take their meds and not have to worry about how much vitamin K they get in their diet? So those are all things that we look on when we're deciding. The duration of their therapy also depends on whether the clot was provoked or unprovoked, but leaning more towards long-term therapy with both provoked and unprovoked, because what we know is that 30% of the provoked clot will have another clot within 10 years, and about 22%, I got that back, The unprovoked is 30%. The provoked is 22%. So still a pretty high risk. 3 out of 10 or 2 out of 10 patients that have a clot will have another clot within 10 years, especially if they stop their anticoagulants. You asked about being consistent dose.
Mhm.
The dosing isn't what needs to be consistent. It needs to be the consistency needs to surround when you take the drug around the same time every day, because patients that are on warfarin will not necessarily have the same dose every day. They may alternate 5 and 10 or 5 and 7.5. I was never a big fan of 5 and 10. That's too much of a swing for me as a clinician. But 5 or 7.5, sometimes they'll do a whole tablet or a half a tablet. I always tried to only use one size tablet to decrease the confusion. So either you take a half a tablet, a whole tablet, 1.5 tablets. Those were kind of my parameters of deciding what dose on the warfarin. Um, and the consistency needs to be around diet, especially with warfarin. You don't have to worry about diet like you with the other drugs, but with warfarin, your vitamin K intake needs to be consistent. Um, what else did you, let me see. I have
What are the risks, and can someone stay on a blood thinner long term?
So the risks, of course, the biggest risk with any anticoagulant or blood thinner is bleeding. That's the biggest one we worry about. The most serious bleeds that we worry about is into the brain. That's why when I did my patient education, I would always tell the patient, if you fall and hit your head, or you take a really good knock to your head and you're on an anticoagulant, you need to go to the emergency room for a CAT scan, because you can only accommodate about a teaspoon of blood around your brain before you can when the brain starts to swell, there's nowhere for it to go. So if you're bleeding, there's nowhere for that blood to go. So early intervention is key to keeping you from having a major devastating event.
What if you just bump your head on a open kitchen cupboard door while you're in the kitchen cooking?
If you do one of these, it's okay. But if you do one of these and you've got an egg that's coming up, or you have a really bad headache, pay attention to your body and just watch. But, especially patients that fall down and whack their head, you figure you're falling at least probably 5 feet. Most people are at least 5 feet tall. So that's a 5 foot coming down. Or if you get hit in the head, you're at a baseball game and you get hit with a line drive, you need to go get checked out and make sure that you're not bleeding.
In this time of year, ice, that's a
Yeah,
problem. We
yeah.
got to be really careful
I
when
know,
we're
I worry
walking.
about that.
Yeah.
As far as long-term complications, there's been controversy on warfarin, whether it causes osteoporosis and loss of bone density or not. I've been doing it a long time. I can't say that I've seen a big uptick of patients develop osteoporosis that you could say, is it because they got older or is it because of the warfarin? So more bone fractures is what the result is of that. But you can see that in, the studies are not conclusive on that. But bleeding is the big one.
Okay. Hey, Diane, what was I going to ask you? I, I I see this a lot with the patients in the support group and talking to my own doctors. It looks like a lot of doctors are kind of steering towards if the patient can take the medication. Eliquis seems to be a really popular choice right now. Is it true that it has a little bit less of a bleed risk?
Not in the clinical trials, it did not. They would like to sell it as that it does, but
Mm.
the trials that were done on different populations, and both drugs were safe and efficacious in preventing clot in VTE patients. And I think the Xarelto arm actually came out a little bit better in the cancer arm, but they're both very safe and efficacious drugs, and I'm very comfortable with either one of them for clot. I tend to support once a day meds because the patient population I had a really hard time remembering to take twice a day. And what I saw when I had my VTE clinic was patients would come in and they would try and stretch their Eliquis out because they'd be given 60 tablets. So they would take one tablet a day instead of one tablet twice a day.
Yeah, and you
Or
need
they
consistent dosing.
couldn't remember to take it twice a day, so they would take both of them at the same time. That's not how the drugs work. It's because of their half-life. So that's why it's important that you take them around the same time every day so that you don't have a period of time where you're not protected because they're fast on and fast off.
Right.
Can I just ask a follow-on question to Todd? So on the DOAC side, we've for the most part we've got Eliquis and we've got Xarelto. Why is Eliquis once a day and sorry, why is Eliquis twice a day and Xarelto is once a day? He's on Eliquis, I'm on Xarelto.
Xarelto. When they did the clinical trials, the efficacy was there for that dosing. So the half-life and the short on, short off, when they monitored the drug levels and the the occurrence rate with once a day Eliquis, it didn't reach the level that it needed to get once a day dosing. So hence that's why it's twice a day.
Okay, then it's good to know because no one's ever explained it. The one time versus two time. And we're not here to advocate for a one versus the other because
No,
they're both
just
great.
take whatever's prescribed.
Exactly.
That's right.
Take what's
The way it's prescribed.
and take
Yeah.
it consistently.
Yep.
Yeah. Okay. Thank you for that.
Okay.
Okay. So let's talk about next about what doctors actually monitor in your blood. I know after I had my blood clot, I didn't realize I had that much blood in me because I felt like I was giving so much of it to do all of these tests. And we get this a lot, like, why are they doing these tests? What is the point of this? So, patients get regular blood work after the blood clot. They don't normally tell us why they're doing all of this, but what labs are commonly monitored? So, you talked about INR. To walk us through what that is, D-dimer, what kind of a test that's used for, and then other tests where they might be testing your kidney function or platelets. There's a lot of discussion about platelets. And how do these results actually affect treatment decisions?
Okay. So let's start at the very beginning. So the doctor thinks you have a clot and they order a bunch of labs when you go to the emergency room. And one of them that they may look at is the D-dimer because the D-dimer is the byproduct of Miss Pac-Man protein C, protein S, chewing it up. So when they measure that and it's 250, they're like, that's a normal level. But when they measure it and it's 15,000, they're like, something's going on.
Mm-hmm.
D-dimers can also be used once patients are off of therapy to determine if there's a lot of noise going on in their system when they may draw a D-dimer while you're on therapy to see how quiet it is. And a month after you come off therapy, if there's equipoise, whether it's safe or not, you draw the D-dimer and it was 300 while you were on therapy and now it's 4,000. It's telling me that you've got more clot than when you were on. And then do you go back on therapy or not?
Mm-hmm.
Then you talk to your provider. The kidney function and we usually recommended kidney function, CBC, and platelets at least once every 6 months. So we're looking at kidney function because some of these drugs are cleared renally. So if the kidney function gets to the point where your creatinine clearance is less than 15, then we would probably switch you to warfarin, even though warfarin, there's no evidence to show that it's better in the renal failure patient. But I think that there's enough comfort now that we use the DOACs in the end-stage renal patient, but that might be one reason that you would check the renal function.
Okay.
CBC, I always check the CBC because they could have a slow leak and you wouldn't know it. So you may be having, microscopic hematuria, or you might be having, a little bit of a bleed, but not enough to turn your stool black, that your hemoglobin has crept down 2 or 3, or your crits dropped down 3 points. Then
What would cause that?
Huh?
What would cause that?
You could have an ulcer. You could have a tumor.
Okay.
You could have cancer. I had 3 men while I was at Emory, and that was when there was just warfarin, who came back and thanked me. They said, "You saved my life." They had hematuria. It was microscopic on one guy. And if your provider tells you you have blood in your urine, blood in your stool, or abnormal vaginal bleeding because you're on a blood thinner, go find another doctor.
Yeah.
These drugs do not make you bleed. They make you bleed faster. So if there's some irritation, the three men all had bladder cancer and
Oh,
were
wow.
able to go on and be treated successfully and live a healthy life because they had hematuria that we said, no, 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 you have to, no, you're going to a urology, and urology, you're going to go in, and sure enough, they go in and they scope them, and there's a small tumor in their bladder.
Wow,
But
that's
I mean,
amazing.
some good does come out of it. That's kind of like not the silver lining, but it has saved people's lives because it identifies other things.
Mhm.
Cancer is one of the things that make people clot.
Yeah.
And if you have bleeding from somewhere, then that points a finger to, is there something abnormal there that's bleeding? Because the tumors can bleed. And then, you get rid of it. So stool, most common with the black tarry stools are, throwing up what we say is coffee ground emesis. It looks like coffee grounds when you puke, is from an ulcer. And the bright red blood from the rectum is usually down in the colon. That's not digested blood. If it comes out black and tarry, that's digested blood, and it smells like something has died. So
Um,
those
let
are
me come back to the D-dimer for a second, because we've had a couple of patients recently. They're going off of, they've been provoked. They're coming off of their medication, their anticoagulant. They're nervous about it, which is understandable. Um, but we haven't had anybody say, "Hey, get your D-dimer checked every so often." I mean, this is something they could ask for, as a continuing prevention method to check, couldn't they?
it could be a temperature taker. You take your temperature. But be prepared. If it's up, are you going to act on it?
Hmm.
So don't don't do it to do it. Do it if you're not comfortable. First of all, if you're not comfortable, don't go off. If there's not a reason for you to come off, I encourage my patients to stay on, because we know that a good number of you are going to have another clot.
Mhm.
If you're not having bleeding problems and you can financially afford it, and it's going to cause you worry and to lose sleep at night, stay on it.
Yeah.
There are other tests that we do. I mean, D-dimer is very non-specific. There are other tests that the hematologist can run. There's a thrombin antithrombin, there's a PF 1.2, there's fibrinogen levels, there's all sorts of sophisticated stuff. But if you're not comfortable, stay on.
Yeah, and that's me. And other patients as well. Like, we're just very, especially on the unprovoked side, very nervous about coming off.
Right.
So but it's good to know that there's testing that can be done to help people get over that hump should they need to. Okay. Todd?
Yeah, and talking about recurrence, another question we hear constantly
Mm.
is, could this happen again? Now, with me, it's happened 7 times. Am I going to rule out an eighth blood clot? No, not at all. Not my first rodeo. But that's a lot of blood clots. And you were talking about, reoccurrence is possible. Why is reoccurrence risk highest in those first 30 days? And what is the long-term risk of recurrence? And then to close that out, what about risk factors like smoking, obesity, immobility, medical conditions, family history? Why do these matter, and how can people reduce their risk, Diane?
Yeah, great questions.
Mhm. So during that first 30 days, you're a hot potato. So there's lots of inflammation going on. You've got clot burden that is going to take a while for your body to dissolve if you're not adequately anticoagulated. If they put you on a heparin drip and your levels aren't right, then that clot can propagate and get bigger. Or if you just go on warfarin and you're not therapeutic right away, it can take, the average is about 2 weeks to get people to therapeutic. You've got to get to a steady state with the drugs. So you've got all of those to contend with. You've got obstruction of a blood vessel, which just, attracts more clotting factors to come there. It's like, what's going on here? Let's join the party. Um, you've got the upregulation of your clotting cascade because something's going on that made you clot. So you need for that to quiet down during those first 30 days. And we don't always know what triggered it. And then you still may be immobile. If it was something that if it was because of trauma or surgery, or whatever, or you've been sick, you're still not moving around as well as you were. So it takes a good 3 to 4 weeks for you to start settling down and for your body to start dissolving that clot. And then if you have a massive clot, you may utilize a lot of your proteins that dissolve clot. You may exhaust your protein C's and protein S's, your Pac-Mans, some Miss Pac-Man. So, you got to wait for those to be regenerated too. So that's the main reason during that first 30 days. Then 30 to 60 days, you've got that cooling off period. Hopefully your pain has started to get better. You're not as short of breath. Your anxiety levels going down a little bit, because that first month you're going to be anxious as all get out, because if you've had a pulmonary embolism, you're like, oh my God, am I going to die? You've got this big swollen leg. Is this ever going to go down? Am I going to be able to wear shorts? Am I going to be left with big bulging veins in my legs because my valves are all messed up in my legs now? So during the next 30 days, 30 to 60 days, things are getting back to semi-normal. The swelling is going down. You're getting back to your day-to-day life. You're exercising. I can't encourage you enough. Start walking as soon as you can. You don't have to wait for a month. Start at 5 minutes a day and then gradually increase till you're exercising 30 minutes a day. Walking is the best thing you can do. It increases your circulation. You don't have to worry about that clot breaking off unless the doctor finds something very bizarre and tells you not to. You should be safe to walk. Then, the pain should start to get better. Now, some people, if you're not getting better, what do you do if you're not getting better? So don't wait. Call your doctor, because there are things that I had one patient with, he was diagnosed with antiphospholipid antibody syndrome. And he was a young guy in his 20s, big leg, and came in, and he was therapeutic because INR was 2.5. His leg just kept getting bigger and bigger and bigger, and we couldn't figure it out. So I consulted with one of our hemonc guys who was very well versed in thrombosis, and so we started monitoring his chromogenic 10 levels, because INR is not a good measurement for people with antiphospholipid antibody syndrome. And lo and behold, when we did that, his INR equivalent would have been like a 1.5. So his clot was getting bigger. So we did not monitor his INR any longer. We did the more sophisticated. So if you're not getting better, or your shortness of breath is getting worse, or you measure your oxygen level and it's below 92, do not wait till you have a doctor's appointment. Go seek medical attention sooner. But by 30 to 60 days, things should be getting better. You should start to see some improvement. Some people are going to be left with permanent damage in their lower extremities from the DVTs and develop what's called post-thrombotic syndrome, which is not anything that's treatable. I mean, there's not anything other than, sometimes they can go in and surgically go in and stent those vessels and take them out, but there's not a widespread treatment for it. So we use compression hose a lot. Controversy, but I never saw anybody have anything bad happen for using compression hose. It increases the venous circulation, pushes it back, and helps with the swelling. So if you're new, don't be afraid to get some compression hose and use it. The studies were done with 30 to 40. I didn't find anybody that could wear 30 to 40 millimeters of pressure. The 20 to 30s will help. So, and they made their legs feel better. And then by 3 months, you should be back to this should be your new normal. If you're still feeling bad, you need to seek attention. And, that's when you're going to maybe go to the pulmonologist, or you're going to go to a hematologist and say, I'm just not getting any better. Not that guarantees they're going to be able to do anything, but don't wait. There are modifiable risk factors that you can take action on. If you smoke, stop smoking. It makes your platelets sticky and increases inflammation. If you're obese, that's an inflammatory state. So it's going to increase upregulation of your clotting cascade, plus sedentary lifestyles and just the pressure from the extra weight on your vessels causes venous stasis, which is pooling of the blood. Immobility, if you're not mobile, you have blood that pools in your extremities, or And where the blood pools, you have extra clotting factors in. So they're just hanging out, waiting to form a clot. And then there's certain medical conditions that you can't modify. If you have cancer, make sure you're up to, or if you have a clot, make sure you're up to date on your cancer screening, that you don't have an underlying colon cancer or prostate cancer or breast cancer. Make sure you go for your routine exams. Those ages are getting younger now. 45, you should be having a colonoscopy. So just make sure you're up to date on those. And just realize that if you are doing chemotherapy for anything, some of those drugs are thrombogenic. So most of the HEMOC people will prophylact patients if they're on a drug that can increase your risk for having a clot.
For people in the audience, a HEMOC is a
A
doctor who's
hematologist, oncologist. Yep.
right. Okay, great.
Sorry.
So what we should take out of this is the first 0 to 30 days is the most critical time frame. Things should start to normalize between 30 to 90. Post 90, if you're still having physical issues, you really need to get with your clinician and talk about, what's going on, particularly if there's shortness of breath still
Right.
occurring.
There's something called CTEPH. It's chronic thromboembolic pulmonary embolism. And there are centers that treat that.
Yeah.
There are medications for that. So that's why I don't want people to wait and just accept if they're short of breath after a PE. You may have to go in and have a right heart cath to see what your pressures are, to see if you're a candidate. But there's some really good centers out there that can go in and interventionally do some things to try and decrease that clot burden in your lungs.
Yeah. Okay. Let's switch gears for a little bit here and let's talk about warning signs and when to seek help.
Let me back up one thing I didn't talk about is family history. We didn't talk about
yes, you're right.
Thrombophilias, which is a big long word for a blood clotting disorder. So if you have a family history of blood clots, but nobody has been diagnosed with anything, that doesn't mean you don't have a clotting disorder. It may just mean they haven't discovered what it is. But just be more, just be mindful when everybody on here has probably had clots, but share with your family members to share with their providers that they have a first degree relative or whatever that has had clots, so they can be on the lookout that they, when you do those medical questionnaires, make sure you fill it out that you had a mother or a sister or an aunt or an uncle that had blood clots, because that can help us risk stratify you for having an event during a procedural time. So that was the only thing I wanted to back up on that.
Okay. And just wanted to make sure somebody in the group had asked what CPEF is, and it's actually CTEPH, CTEPH, which is chronic thromboembolic pulmonary hypertension, which is rare but incredibly serious. And if you are still suffering from shortness of breath after 90 days, you should talk to your doctor about the fact that this is happening to you. Okay. Recurrence, also a really big topic for those of us that are patients. This is a new thing that has happened to your body. You don't necessarily identify everything that's happening in your body because you've never experienced before. So, I want to come back to that about warning signs and when to seek urgent help. So talk to us about, in terms of recovery, what is normal, what's not? What symptoms, and I know we touched upon it a little bit, but what symptoms should prompt someone to call their doctor right away? What are the true 911 emergency warning signs for a possible PE or serious bleeding while on a blood thinner? And, I'll be the human guinea pig. I thought everything that I was experienced was a 911 emergency because I never experienced any of this before. So help us walk through what's super critically important and what's not.
So make sure that you have a provider that you're comfortable with that manages your anticoagulation, because you want to be able to pick up the phone and reach a person, not a phone triage that you have to go and wait 3 days for an answer. So make sure that you have a way to communicate with your provider. Be aware that you're going to bruise and bleed easier. Unexplained bleeding or bruising is when you want to call. So if you have bruises that are just popping up all over and you haven't bumped yourself or that, then you're going to want to call. Or if you have, just out of the blue, you start having nosebleeds and you've been on your anticoagulation for a while and this is new, and it's not, the heat isn't on and you don't have dry, you may need to use nasal sprays, saline spray to minimize we're in the winter months now. You're going to start having nosebleeds if you're in the north and the heat is on. So get a humidifier, keep that air humidified. But if you just start having nosebleeds and they won't stop, I've had patients end up in the ICU with nosebleeds.
Oh, wow.
So if it's a gusher, you go to the ER. But if it's, a trickle, then you may want to call your, especially if you're on warfarin, because it could mean that your INR is up. If you have blood in your urine, you have bright red blood in your stool, or your stools change color, but they're not loose and diarrhea-like, you want to call and get an urgent appointment. You don't necessarily have to go to the ER. But if you're you're throwing up blood, bright red blood, or it's coffee ground looking, that's a sign that you have internal bleeding and you need to go to the ER. If you cough up blood, it's not unusual for you, if you're congested and you cough, to have a little bit of streaks of blood. But if you're coughing up phlegm that's just solid blood, you need to call the doctor right away. They may direct you right to the ER. Do not call your anticoagulation provider. Go right to the ER if you're having uncontrolled bleeding. You can't get it to stop. Go to the ER. Don't try. If you've held pressure for 10 or 15 minutes and it's not slowing down, go. If you have multiple bowel movements, or you have a black tarry stool, that first one, that black tarry stool, is digested blood. Go to the ER, because you don't know what's coming behind it. So that's the first one, is a sign you got a problem. So you will know it's a major change. And a lot of patients may take iron. That'll change your stool black. Yeah. It's not going to be tarry with that extremely bad odor of digested blood. Postmenopausal bleeding is a call to the doctor. And if they tell you that it's because you're on the blood thinner, then you call a different doctor.
Yeah.
So women that have gone through menopause should not have vaginal bleeding. That's a sign of cancer. If you have vaginal bleeding afterwards, if you've had, it can be a sign of cancer. It can also happen if you've had intercourse and it only happens after intercourse. That could be a sign that you may need to talk to your provider about doing something to prevent that. But that was not an unusual complaint from women, that they would have some bleeding after intercourse when they're on anticoagulants and when they were postmenopausal. The younger women should not.
What about chest pains?
Chest pains and shortness of breath is right to the ER. You can't triage that through the doctor's office.
Okay. So right to the ER.
Yep. That could be the sign of another pulmonary embolism.
Okay.
It also be a sign of a heart attack.
And what about for people who've had a DVT, pain in the calf, even if they're on an anticoagulant, they've been diagnosed, if it continues to get worse, if the pain gets worse?
Exactly. Like my young man did. You want to get a hold of your provider and go in and be reevaluated. They can ultrasound, and the devices are so sophisticated now, they can determine what's old clot and what's new clot.
Oh, wow. Okay. So no reason to not go, because that's an easy look. Okay. Okay. So let's transition over to mental health after a blood clot. Because again, so many of us have experienced this and still do experience this, that the emotional side of the recovery is just as hard as the physical. And for everybody who's on tonight, our year-end campaign is about one of our board members, Dan Walsh, who has just been an incredible advocate for awareness about mental health. I encourage everybody to listen to this podcast when it comes out. But so many of us have dealt with this, the emotional side. So how common is this anxiety, and how should a patient know when worry becomes something they need to get help for? What type of emotional support tends to help the most? And you as a clinician, I mean, you've seen this for so many years. What do you do?
So you are not alone, that's for sure. 75% of the patients that have had clot have some form of anxiety because of it. Think about it. I mean, you've got a clot in your leg. You're worried it's going to break off and go to your lung and it could kill you. Or you've had a clot in your lung and, oh my God, I could have died. Or, oh, is it going to happen again? Very, very normal response. And how we deal with it is going to differ from person to person. And if it starts controlling your everyday life, that's all you can think about, or you're persistently anxious, or you're having panic attacks, or you become depressed, or you're thinking about suicide, those are all red flags that you need to seek medical professional help. They may need to give you some medicine to help you get over the hump. Doesn't mean you're going to be on it the rest of your life, but until you become comfortable or more comfortable with it and to be able to deal with it. But I think one of the big things is that knowing you are not alone in this boat, and that 900,000 people a year have a clot,
Mm.
and that there's all sorts of blogs and support groups online, on Facebook, on Twitter, and well, they don't call it Twitter anymore, X, Instagram. There's all sorts of things that you can vent and talk about how you're feeling, and realize you are not alone, and see how other people deal with it. There's some organizations have patient support groups. We never had a good turnout for the face to face, but I will tell you, the online chatter that goes on with, I mean, look at the questions and that we get on our website.
Yeah.
I think patient support groups is key. And then, but just realize that there's nothing wrong with asking for help from a mental health provider to help guide you through what you need to do to be able to be functional and have a productive, meaningful life.
Yeah, I found that the emotional aspect actually, as I transitioned from that 0 days to 90 and beyond, started to become more of an influence negatively in my life than the blood clot did from 0 to 90 days. And I really needed to find someone to help me with that. I will say that finding the group and Todd in particular, guiding the patients in a support group was just outstanding. I thought that the mental health issues that I was having were related to me only. And then I found that there were thousands and thousands of us that are actually dealing with this. So,
We're adding
you
like
know,
20, 30 new patients a day.
yeah,
We have
it's,
almost 12,000. So thanks, Jen, for putting up the link to the support group because a lot of people depend on that.
yeah, for sure. And people should not be embarrassed about this. This is a legitimate thing, and we've got resources, and we've all lived through it, and want to make sure that, the whole patient is being treated, not just the physical side, but the emotional side as well.
Mhm.
Todd, if okay with you, what I'd like to do is let's talk about, I know you wanted to touch on lifestyle,
Mhm.
and then I think we should probably pop into questions because it's already 7:49, and we'll
We
get
need
done.
like 3 hours with Diane.
I know, and we'll
Now it
get,
doesn't
I learn
work.
something every single time, or many things when you join us, Diane. But I do want to get to some of the questions that folks have.
So you want me to go ahead and cover some of that daily life stuff, some of those
Yeah, I
questions
think
I
so,
had?
because I think it's really
I
important.
think it'll go pretty quick there, and there's only a couple, Diane, but
Yeah, I can zip through a bunch of them because I had your questions. So
okay, okay. Well, when we leave the hospital, I say we, Leslie clotted, I've clotted, all of our patients have clotted. When people leave the hospital, they're suddenly trying to navigate all of this in everyday life. They're trying to hold a job, take care of the family, take care of the kids. It's not easy for them. But let's talk about some of that everyday stuff we have to think about. Food. Some of us that may want to have an alcohol beverage, medications, movement. Are there foods that people should avoid or be careful with while they're on their anticoagulant? Why do some anticoagulants need to be taken with food?
Mm.
And what medications or supplements shouldn't be mixed with our blood thinners, including NSAIDs?
okay, so consistent diet is what's the key. There's no foods you absolute taboos. Just be consistent with your vitamin K intake for warfarin. With the DOACs, you don't have to worry about food. Alcohol in moderation. If you want to have a glass of wine, it's I've always allowed my patients to have a glass of wine. It can affect an INR if you binge drink, so you don't want to do that. But the main thing is if you drink too much alcohol and you fall down, you're more prone to bleed and have a head injury than if you're sober. So just be mindful and try not to drink too much. Um, the medications and supplements that you want to be mindful are the ones that can increase your risk for bleeding. So in your stomach, you have something called a prostaglandin that when you take a non-steroidal anti-inflammatory, which are your ibuprofen, Goody's powder, aspirin, Aleve, anything that is an anti-inflammatory, Celebrex, Voltaren, those knock out the prostaglandins in your stomach and increase your risk for a GI bleed. Do I not let them take them ever? No, but I tell patients if you're going to take them, you have to pay extra attention to your stool to make sure you're not having a GI bleed, and only take them as needed, not a daily. So some people that have just terrible, terrible cramps or arthritis, they have to take them occasionally. So those are the non-steroidals. The herbs that we worry about are the ginkgos and the St. John's worts. Those can increase your risk for bleeding. So if you can get by without those, don't take them. And then the other alcohol or exercise and physical activity is good for you. It's good for your mental health. It's good for your physical health. You just want to pick activities that are non-impact, or if you have the chance, I know Todd's a big biker, wear your protective gear, wear your helmets and your pads, so that if you do have a spill, you're not, you've taken as much of the caution as you can so that you don't have a major bleed.
And just so you know, I also wear my abdominal gear. Okay. And I wear my road ID. I always have my med alert on there because it's good for medics to know if you're on something. If you can't speak for yourself, it's good to have that, right? I don't know if you answered this. I don't think you did, but isn't there an anticoagulant that needs food for
Oh, I did, yeah.
effectiveness?
So Xarelto needs to be taken with food because of the bioavailability. So if you take it on an empty stomach, you don't have the efficacy. If you take it with food, you have 98% efficacy. I think it's down to 85% if you take it on an empty stomach. So to be the safest and get the best bang for your buck, take it with food. That's
Okay.
the only
Full
one that
dosage?
take it. And that's only the 15 and 20 milligram dose.
Okay.
If you're on the 10 milligram dose, that does not need to be taken with food.
Okay. You scared me there for a minute.
Yeah.
10.
Leslie, do you want me to move into work and travel, or do we want to go to questions?
No,
What
I
would
think
you
we
like
want to
to
go to
do?
questions, and then
Okay.
because we have so many of them. So if you guys don't mind, we're going to transition over to questions, and maybe Diane, hopefully you don't have plans tonight because we'd like to keep you a little bit longer.
Okay, no worries.
These questions. Okay, so I'm going to take the first one.
Okay.
I had an unprovoked pulmonary emboli. The hematologist said that the following tests weren't necessary since I already had a PE, and the results of those wouldn't change my treatment plan. Factor 2 DNA analysis, antiphospholipid syndrome, protein C, protein S, antithrombin 3, factor 5 Leiden mutation. It seems like most people who have had a PE would disagree. What are the benefits to knowing these test results, and how might a positive result of one of those tests impact someone?
The only one I would be concerned about would be the antiphospholipid antibody syndrome one if you're on a DOAC, because it is not recommended to be on a DOAC if you have those. If you're doing well and haven't had another event and you've tested and you haven't been tested, and it's not going to change your therapy, you're unprovoked. So most providers would agree your long-term therapy. So that's why we don't need to do all those high-end tests, because it's not going to change how we're going to treat you, with the exception of APS. That's the antiphospholipid. That would be the only one. And typically, I would reserve that for women who've had recurrent fetal loss. Those are the types of patients, or if you've had a stroke, those we've seen a fair amount of arterial clots with APS as well as venous clots. So those would be the only ones that I would worry about.
Okay. Todd?
Okay, so a lot of people worry about this. If they're on warfarin, there's a reversal. If you're on a new DOAC like Xarelto or Eliquis, is there a reversal for that in a major bleeding event? And if not, what can be done to maybe stop that bleeding?
No, there's been a reversal agent out for several years now, Indexanet Alpha, and the prices come down tremendously. But the majority of patients don't get it because those drugs are so quick to come on and off that it's not widely used. So, and the bleeding is far less with the fatal type bleeds are far less. So,
And you
it's
said the price came down. It used to be super, super expensive, didn't it?
like $50,000 a dose.
Yikes. Wow.
Yeah,
Okay.
no, it's way, way
Crazy.
cheaper now.
But it
Yeah.
is available should it be
It's
needed.
available, yes.
Okay.
That is crazy. Okay.
Okay. Leslie.
Uh, I'm 28 years old. I survived a blood clot. They're recommending lifelong Eliquis, but I'm an avid hiker, biker, marathon runner, can I continue with those sports?
I don't see why not. If you're a hiker I mean, wear your helmets, wear your helmet and your protective gear, and stay hydrated. That would be the one thing I would be worried
Mhm.
about, would be becoming dehydrated. So that's one important thing that we didn't touch on, was the importance of staying well hydrated. Because when you're dehydrated, your blood is doesn't it is it's more viscous.
Mhm.
Is that why they say that people who live at higher elevation potentially get blood clots because the high elevation actually causes dehydration?
I think so. I think that's the pathophys behind it.
Okay. Todd?
Yeah, okay, so if you've had a blood clot in the past and you're not on an anticoagulant, if you're worried about things, can you talk to your doctor about maybe taking a temporary dose of an anticoagulant for your travel? Is that something that doctors do for patients?
Not routinely, they don't. um, they if you're going on, if you had a clot and you're not on anticoagulant and you're worried about it, that would be a conversation you should have.
Okay.
Or that's when, or do you get your D dimers checked before you're going to do a long distance plane ride where you're going to be 9 hours in a coach seat?
Mhm.
Ugh.
Mhm.
But I don't think routinely physicians would prescribe a one-time dose for anticoagulants.
I imagine if we do those seated exercises, stay hydrated,
Get up
that's
and walk when
really
you
good
can.
prevention.
Well,
Yeah.
and the other thing, the other lovely thing about being on the transatlantic flights or whatever is that you can have alcohol. You don't want to drink alcohol when you're flying,
Mhm.
when you've had clot, because it dehydrates you. So yeah,
Mhm.
just skip the cognac.
Yep. Okay. All right,
Sometimes I
Leslie.
go into the lavatories, into the bathrooms, and I do leg exercise, up and down on my feet just to
Yeah,
get the
it
blood
pumps.
moving, and I walk in place and things like that. Um, okay, I'm 5 months post DVT diagnosis, and the pain that I have is still severe with limited mobility. Will I ever be pain free? What should I do?
She needs to go back, or she or he needs to go back to their doctor, because I'm worried that they've got post thrombotic syndrome.
Okay, thank you.
Let's go back to travel for a second because there was someone in the support group last night. I promised them that I would ask this question. And aside from me saying you got to talk to your doctor about it, I want to get your thoughts on it. If you have an active DVT, a DVT that's just been diagnosed in the last couple of weeks, can you still travel by plane? Can you still take that trip?
Nope, not for 30 days. We usually ground you. 30 days has kind of been around since I've been doing this, is that you're in that high risk. Number one, you're new to anticoagulant. We don't know if you're going to bleed. Are you going to have a GI bleed? We don't know. Is that clot going to get bigger and move? Do you want to be where your normal doctors are? Or the dilemma
Mhm.
happens when patients are traveling and they have a clot and they're not in their home environment. How do they get back home? So, but
Right.
typically 30 days is the benchmark. I mean, have I had patients that have flown at 2 weeks? I do, and they've done okay, but we don't recommend it. And it really depends on the size and the location of the clot. If it's a
Sure.
proximal clot versus a distal clot, if it was a big PE, those kinds of things.
Right. Right. Leslie?
Okay. How can I tell if my clot is fully resolved and has gone away?
You'd have to have a repeat ultrasound, and I would say probably more than half the clots don't go totally away. You form tissue or skin around it, and they endothelialize, so you get a little bump in there, so the vein will never totally go back to normal. So it forms kind of a scar where the clot was, and so that's what I said. You can tell if it's old clot or new clot on the Dopplers now.
For the DVT?
Correct.
What
For the
a,
PE, you'd have to have a repeat angio CT. Or is
okay.
it just a PECT? And I would say the majority of the ones on the PE seem to dissolve. You don't see a huge clot burden. A lot of times when we've repeated them, they are gone. But it is not recommended unless the patient is really symptomatic to repeat that. You just don't routinely do that.
So this is a really interesting question because um, with pulmonary embolism, typically your body will take care of it itself for the majority of patients, correctly? It'll get absorbed back into the body. The blood thinner actually prevents new ones from forming.
Correct. The proteins dissolve it, and then, the D dimers are filtered out through your liver and excreted. But the not all clots dissolve.
So
100%.
coming back to the question about, testing and what have you and recurrence and people being concerned about that, going back to the hospital to get retested for another blood clot because you're concerned you might have one, speaking specifically of pulmonary embolism, is not necessarily a great thing either. Having too many of these CT scans.
Now the exposure to the radiation is there.
Yeah.
So,
So
but
something to think about.
but that should not be that should not keep you from going to the hospital if you're short of breath and having chest pain.
For sure.
You
For
need to
sure.
go and get it checked out.
Okay.
And it may just be, they may just do a D-dimer. That doesn't mean you're going to get a CT if you go there.
Yeah.
They
Okay.
can do a VQ scan. There's other things they can do.
Explain what the VQ scan is for people.
So it's it's the older form of diagnostic. And what we're looking for is you inhale some chemicals, or I don't even know what the isotope is called. And then we take pictures of your lungs and see if there's a mismatch of where the chemical falls. And that's how you have a big mismatch, then it's indicative of clot.
Mm-hmm.
For patients that can't do the CT with contrast, that's the preferred method because the contrast is toxic to the kidneys.
Okay. Alrighty, Mr. Robertson.
So I've got to ask you this, and I want you to tell me as an advocate and as the admin of the support group. I'm just going to tell you that one of the top 4 or 5 things that I hear from patients that they post almost daily, and a big concern, and I can only imagine how traumatizing this is emotionally. But is there any research at all about anticoagulants not just causing acid reflux, but hair loss? I see a lot of patients complaining that they've got hair coming out in clumps after they start the blood thinner. Is it the blood thinner? Is it the trauma? What is it?
There has been research done, and I know that alopecia is the medical term for hair loss, has been found with warfarin, and I have had patients that were on the DOAX report hair loss. So I believe that it possibly could be causing their hair loss. And what you might need to do is change to a different agent. So it doesn't mean that you're going to have it. If you're on Xarelto, you switch to apixaban and you may be fine, or vice versa. But I did, it was very common in the warfarin population.
Yeah, I see more warfarin patients talking about it than
Yeah,
Eliquis or Xarelto. But I also heard that, we were talking about that mental trauma, that
Mm,
sometimes that can cause
right,
like the hair follicles to die
right. Just
temporarily
the
or whatever.
stress, the
The
stress.
stress, right, right. But that's
But thank you,
emotionally devastating.
but thank you for acknowledging that because so often we're
Hmm.
told, no, 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 the DOAC doesn't cause any kind of hair loss. And the reality
Hmm.
of the situation is a lot of people do experience this. So
Yeah.
there is
We don't know if
legitimacy
it's
to the question.
causing it. I will attest to, yes, I have patients that have said, my hair is getting really thin, and when I have to sweep my bathroom floor every day now.
Yeah,
So, and the only thing that's new is I'm on this drug. Well, that's new, and you've had that. So, like we talked about, is it the stress or is it the drug?
combination. Yeah,
But
Hmm.
if
Hmm.
you switch the drug and the hair loss goes away, then
Yeah, there you
right.
go.
Process of
Right.
elimination. Okay.
Yeah, yeah.
Is it normal to have episodes of palpitation after a PE, even when the EKG and heart ultrasounds keep showing normal results?
it's not normal. And it doesn't mean that it's from the PE. You may have an arrhythmia, and it's not going to show up on an EKG unless you're having the palpitations when they do the EKG. So what you really need is a Holter monitor to
Hmm.
where you push the button when you're having the palpitations and it records your EKG during that time. So you can have high heart rate or tachycardia after a PE, but it's usually persistence. Patients will come in. That's one of the classic signs when somebody comes in and their heart rate's greater than 110. It's like, oh, do they have a PE?
Yeah,
Hmm.
yeah, that was me. I think I was
Yeah.
65.
Right after I was diagnosed, I was also diagnosed with PVCs because I felt my heart skip, and I wore the Holter for a week, and it was showing a lot. And then 6 weeks later, they like disappeared and never returned.
Oh, wow.
It was the weirdest thing.
That is weird.
Yeah, let's talk about, so a couple of questions about seeing a hematologist, and I'm going to kind of blend them together. What information should you get or expect out of an appointment with a hematologist, because they tell you to follow up with one? And can you see the hematologist before that 3 month mark? I notice doctors say, well, we'll hook you up in 3 months. As an unprovoked, I would like to begin learning about other causes ASAP, especially because I have pain, but I have great vitals.
Where's the pain? I mean, I don't
Doesn't
know.
say.
I don't know how to answer that part. As
Can they
far as
move up the appointment at all, or do they have, or is it best to
so, I
wait
think
that 3 months?
the 3 month mark is a good place to go see the specialist because you can't come off your anticoagulation for any kind of testing during that acute phase. So you don't want to mess up and have another clot. And so if they've tested you initially for antiphospholipid, there has to be a 6 week period of time between when you get tested again. It's got to be,
Okay.
6 to 12 weeks. So I think that might be, but they want things to quiet down.
Mm-hmm.
You can't really, I mean, there's certain tests we can't do, and it's not going to really change what we're doing as clinicians. And I would say that not everybody needs to go see a hematologist.
Mm.
That what why are they sending you to hematology unless you have an underlying family history of like antithrombin 3, or you have there you can have what's called heterozygous or homozygous. Homozygous means you've gotten the gene from both your parents and you're much more likely to form clots. Heterozygous is you've got one gene from one family member. So, if you have, or if you're really cursed and you have a factor 5 heterozygous from one and a prothrombin gene mutation. So if you're double homozygous or double heterozygous, you're a little bit more risky. So those are the kinds of things that you might want to deal with the hematologist. Or if you're having recurrent clot, that while you're on anticoagulation, have them figure out why the drug isn't working for you. Those would be things to see the hematologist for.
Yes, and so I'm homozygous, so that obviously that's why I throw clot parties. But the hematologist, it doesn't have to be the hematologist that prescribes the anticoagulant. Can't your just provider just do that, right?
Yes, for
Okay.
sure.
Okay. And that patient that asked that question about the pain, and you were asking what pain, where the pain, they mentioned ribs, shoulders, neck, and back, and that sounds like classic referred pain to me from the clot trauma. Am I wrong?
Yeah, it could be costochondritis. I mean, it could be a lot of things. So you need to follow up. It's not typical. That is not something that patients, did they have CPR? Did they have a cardiac arrest? And now they've got all this inflammation from CPR. That kind of stuff would be where I've seen the chest pain. But it's not a typical presentation for PE. So I would definitely need to follow. You need to follow up with your provider for that.
Okay, Leslie.
All right, I'm going to take one more question. How about you take one more question, and then we've got
Okay.
some questions that we want to poll folks, and then let everybody go home for the evening. So this is actually coming from one of the folks on tonight. Is D-dimer at initial presentation helpful for determining if a clot is old? I had two segmental PEs and an infarct, which is probably where the pain came from, and my D-dimer was only 249. I am just still wondering if my clot could have been more chronic from a surgery 4 and 8 months ago or prior. I had no calf symptoms ever, still reaching for a provoked cause.
Yeah, very common for patients to present with, they have imaging done, and we call it incidental finding, where, oh my gosh, they've got a big clot in their lung and they never had any symptoms, no shortness of breath, no chest pain. Um, for this patient, it definitely could have been, if her D dimer, if she went back, is it a new clot or not? I would say it's not a new clot if the D dimers are 240. That would be pretty low. And it really depends on the clot burden. Can they, I don't know what type of testing they did, if they were able to do an angio and tell if it was new clot or old clot. So hard to say, but I would say that it could very well have been after her surgery, and now they're just finding it. But did she say she was having pain now, Leslie?
Uh, I had no calf symptoms ever. Still reaching for a provoked clot.
But why did she go? Why does she find? How did she find out that she had the P? Does it say?
D-dimer at initial presentation.
Initial presentation to
Yeah,
what though? Yeah,
I'm assuming,
to
yeah,
the doctor's office or whatever.
yeah.
Yeah,
I don't know.
yeah.
She can certainly write in if she's still
It
here.
is. It is a non-specific. It's non-specific. So it's not diagnostic. It's important when it's elevated, but it doesn't rule it out. That's why you go on and you do the other testing.
Yeah.
So
Um,
you I guess you could have a normal D dimer and still have a CT PE and have a PE on it. But I
wow.
would think you'd have symptoms. I mean, you
Right.
went for a reason. So if the D dimer would be the first, is usually the first, and it rules out. But then there's a decision tree that you go down. So if X is this and Y is this, then do this. And so D dimer is negative, but patient has chest pain and shortness of breath, or they're tachycardic, or they're hypoxic, then move on to the next step, which would be the imaging.
Okay. I know Todd's going to round us out with the last question. We didn't get to pregnancy and we didn't get to menstruation and anticoagulation tonight because we just ran out of time. But we have a lot of
Told you get too many questions.
well, we had 100 questions come in,
I
and
know.
I really want to get to everybody's questions. We have a lot of resources on those topics in particular on the website, which I know Jen will throw some information into the group, but please feel free to access those resources if you have questions specifically about that. Todd, I'm going to punt it back to you for the last
Yeah,
question.
and I did see a lot of questions of what do I ask the hematologist, and maybe Jen can throw up the link to the questions to ask our doctors because
Oh,
we have a
great. Yeah.
ton of questions in there to pick and choose from. Okay, the last one. Someone's got a DVT. They've had it for a couple of weeks. They're on anticoagulants. They've heard through the grapevine or talking to people that it's not good to take a sauna or a hot tub or even a hot shower. Is that true, Diane?
That's a new one for me.
Okay. That's what I
Yeah.
thought. So you can take a hot. Does varicose veins play into that at all? I mean, that's totally separate, but
No. Yeah.
there's just
Varicose
no
veins.
reason.
Yeah. Varicose veins typically would be, unless you've had multiple clots and done a lot of damage to the veins, isn't something
Okay.
that we saw frequently. So no, yeah.
So grab your one glass of wine and hit the hot tub. You're going to be fine, right?
Well, that's going to amplify the results of the alcohol. So I don't think.
Always something. See, we got
I
to be thinking
know.
about
I
this all
know.
the
By the
time.
way, a little birdie told me that there in 2026 it might be that Diane shows up in the group a little more often. So we might have some information to share with our patients so that we can access you more than once a quarter for the new patient. But just saying,
Wouldn't
just
that be
saying,
awesome?
yes.
Newly retired and available.
All right.
All
You'd be
right.
very popular in the group, I can tell you that.
Yeah, I mean, I have a great passion for Clot. I don't know why I liked it so much.
Shows.
I'm a weirdo, but Clot was always my passion. I liked it way better than AFib.
Well,
Oh, I
let's
wish I
talk
had met
clots.
you
I,
when
I
I
think
was
because there's
diagnosed.
more mystery. There's more mystery to it, and
Hmm.
someone with AFib definitely doesn't have the anxiety that somebody, and it's a younger population. So I feel like Clot patients were a lot younger.
Yeah,
Mhm.
So
yeah, that's
Thank
true.
you. All right, you've got some post questions for the
So
team.
Jen's going to throw up some questions. We just want to ask, I think it's just three questions again here to close out the episode. If you folks could just hang on for a second and answer these. Did tonight's discussion help you understand your diagnosis a little better? Yes, no, not sure. Will tonight's discussion make you more informed to discuss your diagnosis with your doctor? Yes, no, not sure. Did tonight's discussion make you more confident understanding your anticoagulation treatment? Yes, no, or not sure. I've made my choices. We're going to read the results as soon as those popped up and let you folks get on with your evening. I kind of love OT. I love overtime.
Me
Play
too.
overtime with Diane. Okay, here we go. Did tonight's discussion help you understand your diagnosis better? 88% said yes, and 4% said no, 8% not sure. Will tonight's discussion make you more informed to discuss your diagnosis with your doctor? 89% said yes, only 2% said no, 9% not sure. Did tonight's discussion make you more confident understanding your anticoagulation treatment? 87% said yes, 9% no, 4% not sure. Overall, Leslie, pretty positive.
I think so, and I think this is an indication that we need to get Diane back into the group on a more regular basis. So first of all, we want to say happy holidays to everyone who has joined us tonight. Wishing you wonderful health the rest of the year and forever. And Diane, you are a treasure. Thank you so much for joining us again. And I would also like to say, Todd, you are also a treasure and you do so much in the group, and we all want to thank you for everything that you do as well. So
Well, we all love you too. We just
happy
love everybody.
holidays. Happy holidays, everybody. And we'll see you in January. We've got another great PEP coming up in January.
Stay safe, everyone. Bye bye.
Bye.
Bye bye.